My name is Dr. Vivien Brown. I'm an assistant professor at the Department of Family and Community Medicine at the University of Toronto, and I have the great honor of being chair of HPV Week and chair of the HPV Task Force. We've had webinars this week, we've had a big panel discussion, and today we're going to finish up by talking about head and neck cancers that we now know are vaccine preventable. Before I start the actual presentation, I wanted it recorded, I wanted it to be here online. That the Federation of Medical Women of Canada is incredibly grateful to Dr. Michael Reid for the work that he's done in the last couple of years as executive director, and certainly on the HPV portfolio, which ended up being 4 separate initiatives this year between the HPV Week, the Cancer Won't Wait initiative with newsletters, the Centers for Excellence, and the task force. I couldn't have done any of this work without Michael, and I just want it known that his work has been exemplary. So thank you, Michael. Okay, so let's talk about head and neck cancers, and then I'll open it up for discussion, and we can talk about any of the vaccines or anything you want to talk about. As a reminder, HPV is a very common virus. About 80%, 75 to 80% of adults will be exposed to HPV at some point in their life. Some serotypes of HPV lead to warts. Some serotypes lead to recurrent respiratory papillomatosis, which is a disease of infants where they keep getting papillomas in the throat from having picked up HPV in the birth canal. But HPV goes on to cause many high-risk serotypes, and these high-risk serotypes can cause precancers and cancers at many sites. The most common one that we're familiar with is cervical cancer. And what we now know is that when we have an uptake of vaccine, close to 90% of women under the age of 25, we essentially eliminate cervical cancer. There's other anal genital cancers that affect both men and women, and head and neck cancers affect both men and women, but for some reason affects men preferentially. So it's about a 3-to-1 relationship in terms of head and neck cancer, men to women. Well, when we look at the burden of disease, what we know is that HPV-9, which is the current vaccine in Canada, really can decrease these cancer rates dramatically. And so these numbers here are showing you, for example, cervical cancer, the 9 serotypes cause 90%. What we don't have is we don't have the equivalent for head and neck cancers yet, but we do know that the most common serotypes for head and neck cancers are 16 and 18. And 16 and 18 are what is in both HPV-2, which was the bivalent vaccine, HPV-4, which was the quadrivalent vaccine, and HPV-9, which is the monovalent vaccine. This is looking at the estimated number of cases, and what you can see is genital warts, men and women still are the number of cases at the base of the pyramid. So this is a common reason to go to the doctor, a common reason to be seen. It costs the healthcare system a lot of money, but it's not causing cancer. When we move up to the cancers, you can see that the combination of oropharyngeal cancer in men and women is now outpacing cervical cancer as the #1 cancer, HPV related. We then see cervical cancer, vulvar and vaginal cancer, move up to anal cancer, and we see it more in women than men, and finally penile cancer. Well, if we just look at the burden of disease of HPV in women, you know, because we talk about the cost of the vaccine, but I think we need to talk about the cost of not being vaccinated. We do in Canada about 4 million Pap tests, about 325,000 are abnormal. We see about 77 newly diagnosed cases of genital warts, VIN, which is vulvar cancer, vaginal intraepithelial neoplasia. VANE is vulvar intraepithelial neoplasia. We end up with about 1,800 cases of newly diagnosed cancers. And the statistics in the last 10 years show that we get about 500 deaths in women from cervical, vulvar, and vaginal cancers. If we just look at cervical, it's about 340. And so I've used the phrase a death a day. We get about a death a day of cervical cancer, even with the best resources for Pap tests, even with the ability to now screen for HPV if we choose to, and even with the accessibility of vaccine. So we need to do a better job. That's what this is all about. And what we know when we look at cervical cancer is it peaks in women in their 30s to 40s, and then has a second peak in women in their 70s. But if you look at the gray bars, the mortality goes up with age. So we do see older women, 60s, 70s, 80s, dying of cervical cancer. Now, they may not have been sexually active for years. They may have been exposed years earlier, but as their immune system is less robust, we start to see these cancers again. Well, let's talk about men, and let's talk about the various cancers. What you see here is a picture of genital warts. That's over here. This is anal intraepithelial anal warts. This is anal intraepithelial cancers. And here are some throat cancers that are just starting. This is a look at the larynx. And so what we know is there's a spectrum of disease. And what's new and what's important is in the last 6 months, we just got Health Canada approval to use the HPV vaccine to decrease the risk of these head and neck cancers in men. And I'm often asked, what is the evidence? And the answer is the immunogenicity data is wonderful. It increases the immune system's ability to respond to HPV. That's the same level of data that we had in 2007, 2008, when we launched the vaccine for girls and preventing cervical cancer. So the initial data looks at precancers in women, looks at immunogenicity in men and women. It'll take another 10, 15 years before we actually can say that we have a decreased rate of cancer production. And that's because it takes a long time to see that benefit. We're just now 10, 12 years after vaccinating women, starting to get the research proving that there's a decrease of cervical cancer in vaccinated women. Well, what are the risk factors for head and neck cancers? The older risk factors were alcohol and tobacco use, and those were the most important. But there's newer risk factors that include occupational exposure, radiation exposure, Epstein-Barr infection with cancer of the salivary glands. Certain nuts and betel leaves cause an increased risk. And being of Asian ancestry, particularly Chinese ancestry, is a risk for nasopharyngeal cancer. But nasopharyngeal cancer is not the same as head and neck cancers. The head and neck cancers that we're seeing that are HPV related don't necessarily have these risk factors. What we're seeing with HPV related cancers, sorry, I'm just trying to go to the next slide. What we're seeing with oropharyngeal cancer, so that's not nasopharyngeal, this is oropharyngeal. This is the back of the tongue and the soft palate, and tonsils. What we see is there still is a relation to alcohol and tobacco use, but we're also seeing type 16 as a risk factor for these head and neck cancers. And what we know is we know that the overwhelming majority of oral HPV infections are sexually acquired, more than 90%. Sexual behavior is now established as the most strong and consistent risk factor for oropharyngeal cancer. And the lifetime number of oral sexual partners seems to be the behavioral measure most strongly, consistently, and specifically associated with oropharyngeal cancer. And so globally, when we look at the details, we found that about 30% of oropharyngeal cancers are caused by HPV, but this varies widely, the highest being in more developed countries, over 40% in Europe, North America, Australia, New Zealand, Japan, and the Republic of Korea, and much lower, less than 20% in less developed countries. In the US, oropharyngeal squamous cell is the most common HPV-associated cancer. And when we look at the data over the last 20 years, what we see is that HPV-related cervical cancer has decreased by 1.6% per year, whereas we're seeing the HPV oral cancers increasing significantly, more so in men than in women, but increasing in both. And in 2015, the latest data that we have, the oropharyngeal squamous cell was the most common HPV-associated cancer, with about 15,000 cancers in male and about 3,000 cancers in females. Again, this is US data, but we can extrapolate. We're very similar in Canada, just about 1/10 of the population. And so, sorry. Yes. If we look in Canada, what we see is that the rate is about 4.5-fold higher in males than females. And it's increasing in both sexes, but at a much faster rate in males. And so at the moment, when you look at this graph, what you can see is cervical cancer and oropharyngeal cancer are about neck and neck, with the other cancers being about 30%, but these numbers are going up with time. And so we extrapolate and we see that these numbers are increasing. And when you speak to ENT surgeons, and Dr. Danielle McNeil spoke at our annual general meeting in Vancouver last weekend, she's an ENT surgeon in Hamilton, Ontario, and she spoke about how common it was now for her to see these cancers. And it wasn't when she started in practice about 10 years ago. And here's a graph that's showing you a similar thing where you're seeing the oropharyngeal cancers in orange going up and cervical cancer going down. So we've done a great job with cervical cancer. We're immunizing the population. We certainly need to do better. And we've talked about the school-based program this week. We've talked about the numbers not being high enough and how we're missing out on young people between grades 7, 8, and 9 who have missed their opportunity to be vaccinated. But even with that, the numbers of cervical cancer are decreasing. When we look at the global cases, we see that 90% are HPV related, as we've discussed. And again, we're focusing on 16 as being that oncogenic aggressive serotype. The CDC in the US estimates that 70% of oropharyngeal cancers overall are caused by HPV. And what we know is that HPV cancers are sensitive to chemotherapy and radiation, and hopefully you don't have to do major invasive surgery in order to get these cancers, because you can imagine the morbidity after having to remove a cancer at the base of the tongue in terms of eating and swallowing and talking, because there is huge morbidity with these cancers. But having said that, the cancers that are HPV related are actually more likely to respond to chemotherapy and radiation. Well, there's data that's looking now at the proportion of cancer that is rising, and we have now Canadian data that shows comprehensive cancer centers showing this data in Canada, which I think is why Health Canada was interested and aggressive about approving the vaccine. The risk of suicide in head and neck cancer survivors is high, and that's because of the morbidity of this disease. And I just want to tell you about a patient of mine who is gracious enough to share his story on our new website. The website is canadaversushpv.ca. And my patient had head and neck cancer diagnosed about 10 years ago. He presented to me with a lump in his neck. And the bottom line is he has survived his cancer, but he's lost about 80 pounds. He can't swallow at all, so he can't eat or drink at all. He has a gastric feeding tube. And because he can't swallow and because he can't eat, he also cannot talk. And so his whole life has changed and his whole quality of life has changed. And although he has a wonderful relationship with his wife and they are very connected, he's socially isolated. He doesn't invite people over because he can't talk, he can't eat, he can't go out for a coffee, they don't travel. He is linked to his feeding tube and is very restricted in terms of what he can do. Well, we know that for some people, there is an increased risk of suicide, and they may not have a partner, and they may not feel that they can cope with all these changes in their quality of life. And suicide rates in head and neck cancers are twice as high as suicide for other cancers. The morbidity includes depression, and as I've told you, the facial disfigurement, the difficulty swallowing, the loss of taste and smell, the difficulty speaking, as well as the major change in quality of life. So let's move on and look at the cancers. And I just want to remind you that the bivalent cancer was 16 and 18. The quadrivalent was 16, 18, 6, and 11, which caused the anal genital warts and recurrent respiratory papillomatosis. And the HPV-9 vaccine, which essentially added 5 extra serotypes, mostly associated with cervical cancer in older women. Well, there is no data looking at the efficacy and safety of the 4-valent vaccine in terms of preventing cancers. I've told you that's going to take 10 to 15 years before we have that. But we do have population level impact studies that have evaluated the correlation between HPV vaccination and the prevalence of oral HPV infection. We have immunogenicity data. We know people respond to this vaccine. And so with that in mind, and with watching the course of how we handled cervical cancer, and then eventually anal cancer, we're looking at head and neck cancers following the same trajectory. And so there's been a prevalence of vaccine in multiple countries. And what we know is that the vaccination prevents the oral cancers, including high risk. And what we're seeing is that it decreases your likelihood. So we're seeing a trend. We don't have that hard and fast evidence just yet. Well, what countries have approved this vaccine? The US. Canada was about 6 months behind, and Canada has approved the vaccine. We don't yet have NACI, or the National Advisory Committee on Immunization guidelines around head and neck cancers. But it's normal when Health Canada approves something for NACI to take 12 to 18 months before they come out with their recommendations. They may come out sooner because they're very familiar with the HPV data, but we know that NACI will not look at a vaccine until Health Canada approves it. So we're in that time frame for NACI to start looking at this. United Arab Emirates, which includes Dubai and Abu Dhabi, have approved this vaccine. And Taiwan, remember I showed you that there's a higher incidence of nasopharyngeal cancers in the Chinese population. Certainly Taiwan was very interested in this vaccine to at least eliminate the HPV-related cancers. Again, about 70% of head and neck cancers are HPV-related. So our guidelines from NACI, our guidelines from NACI are from 2018. There is no guideline yet on head and neck cancers, but I wanted to remind you that NACI says the vaccine is recommended age 9 to 26, and above age 26, there's no upper age limit. That's for boys and girls, men and women. And I would encourage you to talk to every patient on every visit about vaccination. What are their options? What are their choices? What's the best thing for them to do at any given time? The Society of Gyne-Oncologists have come out with a statement, and these are the people that see the cancers. These are the people that see the devastation that HPV causes. And the Gyne-Oncology Society of Canada went one step further in their white paper, which came out about 2 years ago. And what they said is they actively recommend, not just support, a universal HPV vaccination program in Canada. What does that mean? We should be immunizing everybody, boys and girls, men and women, a universal HPV vaccination program. And these are from the cancer physicians. They also have a statement from the Canadian Society of Otolaryngology, Head and Neck Surgery, and the Society of Obstetrics and Gynecologists. And they got together and came out with a statement that said vaccination, screening, and early detection will eliminate HPV-associated cancers. And a statement from those societies said, we encourage HPV vaccination of all males and females aged 9 to 45, or any age with ongoing risk of exposure to HPV. So what does that mean? I mean, what do the gynecologists know about head and neck, and what do the head and neck surgeons know about sexually transmitted disease and vaginal issues? The bottom line is it's all HPV related, and we should be coming out with clear statements from the various societies, clear, repetitive statements, whether it's the Ministry of Health, whether it's the Ministry of Education, whether it's GOC, whether it's the Federation, whether it's the Society of Obstetrics and Gynecologists, whether it's the dentists, whether it's the ENT people, the otolaryngologists. The statement should be the same. Supporting or recommending vaccination for all men and women. Age is unrelated. The Alberta Dental Association and College came out with a statement as well, and they said HPV is so common that nearly everybody will get it at some point. The vaccine helps protect against HPV and the cancers it causes, and oral pharyngeal cancers are the most common HPV cancer. So we need to look and see what our colleagues are talking about. And we should be talking to dentists, we should be talking to pharmacists, we should be talking to nurse practitioners, our colleagues, our patients, because we're all on the same page here. And what we're trying to do is to reduce these risks of cancers. What do patients want to know? Patients want to know 3 things. Does it work? Is it safe? And doc, what do you think? Are you taking this vaccine? Are you giving this to your son, to your daughter? What is your opinion? I think we need to be able to answer that question on every vaccine, but certainly in terms of HPV vaccine, we've got more than 15 years of efficacy already, and we're starting to see the drop in cervical cancer. So we know this vaccine works very well against HPV oncogenic serotypes. We know it's safe. It's been monitored with a fine-tooth comb from every agency, from the World Health Organization to Health Canada, to the CDC in the States, to the Europeans. Everybody has evaluated this vaccine, and we have no ongoing concerns. There are no new safety issues. This is a very safe and well-tolerated vaccine. And what do I think? I want to be clear. I want to be proactive. I want to prevent cancer. When I talk to my patients, I make it very clear. I have a vaccine to reduce your risk of cancer. Why wouldn't you take this vaccine? If I could reduce your risk of breast cancer, colon cancer, lung cancer with a vaccine, we'd all run for it. So let's be clear about HPV vaccine preventing cancer. I think every patient visit is a vaccine opportunity, and we should be talking every day to every patient about vaccine. We've been talking about COVID vaccine endlessly, and that's been great. And we've got some models from COVID vaccine implementation that are excellent. We brought vaccine to the community. We used mobile health units. We did all kinds of things to get people immunized. And that's the kind of thing we need to do with HPV vaccine. We need to have every encounter an opportunity to discuss immunization. So I'm going to end with saying that I think immunization is a team sport. And, you know, one of the reasons I went into medicine many years ago and I didn't go into law is because I liked the idea of being on a team and not being out to get the other person. You know, in law, it's very not controversial. There's a combative aspect to it, where in medicine, it's collaborative. It's all about collaboration. So let's collaborate with public health, with pharmacies, with industry, with private insurance and employee benefits. The education system has such an impact on whether parents say yes or no to a vaccine in the school-age population. We need government to get on board. We need government to reiterate the message and have clear messaging that comes out from both the Ministry of Health and the Ministry of Education. We certainly need physicians, we need nurses, we need everybody on board. And that way we will protect our patients. So thank you so much. I'm going to stop here. I'm going to stop screen sharing, and we can open it up to questions or discussions about this vaccine, about this presentation, or about anything else you're interested in discussing.